All right, welcome everyone to our weekly Q&A and our very first week one of our 30-day GOPex growth challenge. So welcome everyone to our week one. So Simon, we have a lot of questions submitted, so let's start with that first and we'll get into the challenge um, discussions a little bit later. So you got the Q&A. So thank you, Dr. Dutton, Dr. Casey, Dr. Tang, for submitting your questions. Over to you.
Okay. When we expand in the primary dentition, for example, 4.5-year-old with an intermolar width of 26, theoretically the sixes will erupt at 29. You mentioned to the dentist she will need to expand about 8 mils to achieve 36, 37 intermolar width. So he's suggesting that we expand all the way to 36 in the primary dentition using the primary dentition expanders. No. The 36, 37, 38 mil intermolar width refers to the sixes. So the E's have to be 3 mils less. Or your permanent molars will be too wide. So you still have to do basic mathematics, yeah? But you can't predict where things are going to end up in the primary dentition as easily if you're doing expansion. So you have to be more conservative. And you have to gauge it according to sufficient space for the permanent incisors. So it's less precise, more eyeballing, thumbnail sketch type scenarios in primary dentition. You mentioned if you start in the primary dentition, you want to finish in the primary dentition. Do you mean that if you start expanding in the primary dentition, go all the way to your final intermolar width using the primary dentition expanders? When you are trying to develop transverse width, the goal is to get enough room for the permanent incisors. So you do have to expand sufficiently for the permanent incisors. And generally, that will mean your primary dentition intermolar width will be 3 mils less than your permanent dentition intermolar width. And if your goal is 37 mils for your permanent, then you've got to have around 33, 34 mils for your primary dentition intermolar width.
Dr. Dutton
All
just
right, next
submitted.
question. For upper
One
Montanus,
second, Simon. I just added an additional question from Dutton. I think she mistyped or whatever. She said, sorry, do we aim to expand to 38 millimeters minus 3 millimeters in the primary dentition? Does that make more sense?
um, as I said, you've got to be a little bit more conservative, but sure. Okay, for upper wong retainers, do you generally want palatal acrylic touching snug against the lingual cusp of the sixes, assuming you don't need to upright a plunger palatal cusp? So the design of any retainer is depending on whether you've completely finished and you're just holding, or if you still want to do some tweaks and adjustments. So if you don't need to make any tweaks or adjustments, then any retainer design can work. Holy retainer, my retainer. I'm just trying to make sure that everything has some contact with your appliance so that nothing moves. Most of my retainers are done after the expansion, but prior to the completion of the final settling of the permanent incisors and the 6-year-old molars. So more often than not, I've got labial bows, I've got approximating wires for the anteriors, and I will need a rest wire that's free of acrylic for the 6-year-old molars to control the plunging cusps that sometimes can occur on the upper. But yeah, if you have everything exactly where you want it, then you have acrylic all the way to the 6s. The arrest wire works just as well if you're just trying to keep the 6 in place. So generally, I don't have acrylic against the 6s because I'm still making adjustments, but if you're finished with all movements, then it's fine to have acrylic. It's fine not to have acrylic, just the rest. So you just make your design according to what you're planning to do with the appliance. Doesn't matter if it's a retainer, doesn't matter if it's an active retainer, doesn't matter if it's an active expander. The design is determined by what you want to do with the appliance. For the cat wire placement, you mentioned you want them ideally on the cingulum. As far as the ideal position of both cat wires in relationship to each other, you drew a picture of a tooth last week where one wire was vertically below the other in incisors. I get confused on whether the wire should be on top, either vertically or horizontally. Picture shows them stacked vertically as opposed to how the appliances rifle in lab with wires stacked snug against each other in a horizontal position. Can you please clarify? A lot of it depends on how deep your bite is. So if you have an open bite or 20%, 30%, even 50% deep bite, and you can have the wires stacked vertically, one on top of each other. If you've got a much deeper bite, then the top wire is going to clash with the lower incisors. So then you've got to have effectively one row of wires and you have them stacked horizontally. So I don't mind how they come from the lab because I adjust wires to suit my needs, irrespective of what comes to me. But when the bite is deep, you have to have one plane of wires. When the bite is less deep, you can have two. Or ideally, you have them stacked vertically. In deep bites, you have to often have them stacked horizontally. Well, but yeah, if we can have them stacked vertically, have them stacked vertically. That's my preference. Then the wires don't clash with each other as the expansion occurs. If you have them stacked horizontally, the wires can clash as one kind of bounces off the other as it expands. Okay, next question. In the GOPex ebook, it recommends sitting with both feet flat on the ground support, which often means the child ends up with only part of their buttocks on the chair. How does this work with an adjustable chair, where the child can sit all the way back against the backrest but still have proper foot support? The lean against the backrest or sit further forward, still better. So, ergonomics of sitting. I'm going to answer this in a couple of parts. One part of the equation is every bit of furniture that we have available to us, as a general rule, is built to a general size. And that general size are usually for medium-sized adults. So anyone who isn't a medium-sized adult with medium-sized length limbs tends to either not fit with the chair being too big or the chair being too small. And that's just the reality of life where, um, you know, we don't have customized furniture. We just have generalized furniture. You have, of course, some furniture that's designed for infants and toddlers, right? So the high chairs, baby chairs. But there's not often a lot for kind of those in-between sizes. There are some specialist manufacturers who make specialized furniture for growing children. And of course, if you have access to that, if you want to spend the money, by all means. The reality is we just have to make do with what we have. And we adapt. All right. In most circumstances, chairs are designed so your knee sits roughly at the edge of the chair so that your lower leg can dangle off it directly towards a perpendicular angle to the ground. For most people, it does mean that their back and buttocks don't reach the back of the chair, whether it's a small adult or a young child. Usually, the compensation is you put a cushion between your back and the backrest so that you still have some form of support for your back. Ideally, your core muscle should be strong enough that you don't actually need the back support. So whether there's a back support or not kind of depends on how strong your core is. And theoretically, we should be able to sit just as comfortably on a bench as a chair with a backrest. The reality is most of us kind of have very weak core strength, so we rely on the support of a backrest to give us that aid to overcome gravity. The main thing, of course, is you should have sufficient support between where your butt ends and where your knee starts so that you don't fall off chair. So that's basically the goal. To have knees at the edge, and you're as far back as you are. depending on the length of your legs. Goal is to sit upright and work around that scenario. The reality is, younger children sitting in an adult chair in that position will have the table edge far too high up for them. So, cushions are usually the way we overcome, whether it's for under your butt or behind your back. In adjustable chairs, in that perfect world where you have funds to do what you need and the adaptability to adjust for a growing child, is you set it up so you have that squared relationship between your feet and your knees and your butt and your shoulders and your arms and your elbows. The reality is we just have to make do with what we have. Second part of the equation is when we created GOPex, one of the consultants that that we used was for the body posture and the ergonomics of furniture. That was Esther Gockler, or Gockhale. And she was the one that helped us understand correct body posture, seating posture, whereas obviously my expertise is in oral posture, and my focus is on oral posture. So in the book, the recommendations for sitting posture, standing posture stem from the Gockhale method, and they sometimes advocate for specialized ergonomic chairs. So to some degree, it's not a primary focus for me. It was a primary focus for Dr. Sandra Kahn. So that's why that was included in the process. And the references that you should look at stem from the Gockhale Institute. So follow do some more research regarding Esther Gockhale and maybe try to find out a little bit more information for ideal situations for sitting for children. Irrespective, we can still focus on correct oral posture at the meal table, independent of whatever chair we happen to be sitting in. Next question. Can a missing tooth or teeth affect the ability to achieve a proper palatal seal? Single or even a few missing teeth won't make any real difference. Your arch ball and your skeletal relationship is more important than individual teeth being present or missing. All right, so long as you can get a reasonable occlusion and achieve fairly even contact in a bite relationship, and if you have a reasonably sized palate to tongue relationship, and you have good nasal patency and airflow, then they're the important things to achieve palatal seal. Whether all the teeth are present or some of the teeth are missing, or even if even in a milder malocclusion, you can still achieve a palatal seam. Okay, next question. In a few cases I've seen from the cohort with two planes of occlusion, you said that the maxillary teeth are more important than the mandibular teeth for the curve of Spey. Can you help me better understand this? Is this because of specific cases having more curve in the maxillary cusps or general rule for all patients? Example, skeletal open bite. So in skeletal open bites, the curve of Spey is usually negative. You have an anterior open bite, effectively. So anterior open bite, you have negative curves of Spey. And of course, depending on whether you've got a larger negative curve of Spey in the upper or lower will determine your focus. But the correction that we do in skeletal open bites and postural orthodontics is very specific to a process called DE extraction. When we have a skeletal open bite and a negative curve of Spey so that the front teeth in the middle don't meet, we run into a scenario where usually only the molars meet. So the 6-year-old molars, the E's and the D's, they meet, but the incisors, anterior teeth, they don't meet. That's because we have a divergence in the growth and development. And so the front teeth don't meet, so you have what we call a negative curve of Spey. So in order to close that anterior open bite, you have two options. You have either extrusion of the anterior segments, or you can have intrusion of posterior segments. So extrusion of the anterior section is usually a little bit simpler because extrusion is the easiest of all movements to achieve. Intrusion of the posterior segments is much more difficult because that's the opposite of easier. Intrusion being the opposite of extrusion, and so therefore the easiest movement being extrusion by default means intrusion is the most difficult. We have less issue with extrusion, in particular of the anterior segment, because you're only dealing with one row of teeth. Whereas if you're trying to intrude the posterior teeth, you're dealing with many sections. Right? The 6-year-old molars, the E's and the D's. So I'm assuming we're talking about primary dentition management, right? So in postural orthodontics, if we have a very specific scenario where we have a negative curve of Spey, contact only in the 6-year-old molars, the E's and the G's, and the skeletal open bite, as well as the dental open bite, then we can do a treatment where we intrude the 6-year-old molars to the same occlusal plane as the anterior teeth, and then we extract the E's and the D's to allow a closing auto-rotation so that intrusion of the 6s and extraction of the E's and the D's effectively resets the posterior occlusal plane so that when the mandible rotates in the closing relationship, the anterior teeth can meet and effectively flattens the curve of Spey from one that was negative. Intrusion, being the most difficult, has two grades of difficulty. Intrusion in mandibular bone is significantly more difficult than intrusion in maxillary bone. So we tend to focus our intrusive force on the upper first permanent molars. It's very difficult to intrude molars in mandibular bone. It's not easy in maxillary bone, but much, much easier than in mandibular bone. So we focus our energy and attention in the maxilla in these treatments. So we intrude the upper sixes and we extract the upper E's and D's. We tend not to do too much in the lower arch because it's very hard to achieve any intrusive movements in mandibular bone. And that's why our attention is on the upper arch. Okay, when treating children with skeletal vertical access, long maxillary gummy smile, what are the reasonable expectations from the parents? Is it correct to inform parents our goal is to achieve enough room with expansion and allow best AP growth with postural GOPex? So the gummy smile will likely remain in the vertical axis. So expectations. We have 4 dimensions that we're dealing with. Transverse width, AP sagittal, and vertical height, and age time. They're the 4 dimensions of life. When we have vertical excess, we will also have transverse issues and AP issues. The first thing that goes wrong in growth is excess vertical, which usually leads to AP discrepancies, which then follows on with insufficient transverse dimensions or out of balance transverse dimensions. All right, so the first error being a postural open resting posture will lead to increased vertical, which by default leads to AP discrepancies because your mouth is open and it swings down and back. And then you get collapse of transverse dimension as the final straw. This happens over time. So when we are trying to correct excess vertical, we have a scenario where we have a noticeable excess vertical. Noticeable excess vertical means that it's a very severe issue. Not just a little bit crowded, not just a little bit out of whack with AP, not just a little bit long of the face. When we have excess vertical, we know that all the dimensions are completely off. Like completely. Everything is out a long, long, long way. By definition, vertical excess, when it's so noticeable that it's the first thing you notice, is the most difficult of all malocclusions to correct. Because not only do you have to correct vertical, AP, and transverse, but you're also more often than not dealing with an airway obstruction. Because the vertical excess stems from having the mouth wide open for a long period of time. The primary cause of having your mouth open wide for a long period of time is that your nose is completely nowhere. So you're dealing with a long-standing, very, very bad postural issue. So what's the expectation? Well, parents want everything to be picture perfect, fixed to 100%. Right? That is the expectation of their young child. When you have a young child, you are aiming for the moon. No? That's just the reality. What's the reality? The reality is you're probably not going to be able to achieve much change at all in the vertical dimension. Right? You're going to struggle to get anything out of AP improvement. You will be able to make transverse dimension changes. Why? Transverse dimension can be addressed very effectively by the appliances that we use. Right? The expanders. Why are they so effective? Because it's the simplest of all the malocclusion component issues. Well, expanding is relatively easy. Why is AP so difficult? Why is vertical so difficult to manage? AP and vertical have very little to do with appliances and a lot to do with posture. AP improves when the posture is good. Vertical improves when the posture is good. What stops the posture being good? Most often in excess vertical growth children, it's their nose doesn't work. What are some of the blockages? It could be allergic rhinitis, could be enlarged adenoids, enlarged tonsils. They're the most common. They're the most common of the blockages. Adenoids and tonsils can be removed surgically, and once that happens, the nose can start working again and you can improve the posture. Allergic rhinitis is almost impossible to resolve, and their nose remains congested and blocked for most of their childhood life and often into their adult life. And in those circumstances, their mouth is going to remain open no matter how much expansion you do. So the development remains vertical and the AP remains out of whack, despite any width development that you may make. So what's a reasonable expectation? We can expand to make room for the front teeth, and if we can train the child to keep their mouth shut at rest, then we can stall the free fall in the vertical and reduce the discrepancy between the AP. And that's how we put it to the parents so that they understand. And until you understand this growth and development slide, then you can't explain it to the parents and they won't understand it, and why they won't understand how important the exercises are, but equally how important it is to get the nose clean and to get the pharyngeal spaces clear. So surgery when you need surgery, whatever sprays you need for the nose, and whatever it takes to get away from the allergic stimuli. Get rid of the pets, move house, move city, move state, move country, whatever it takes, right? Right, most people have to make do with where they are and who they have in their lives. So it's very difficult. What step value do you keep as a range for when they're likely to need surgery later? Is this the increased lower anterior face height that exceeds the normal average of 65 to 72 millimeters? So the reality is you've got to look at the normal range, and if they're a long way outside of the normal range, then danger, Will Robinson. Even if they're a little bit outside of the normal range, the reality is excessive vertical growth increases with time. It's very rare that excess vertical growth stabilizes or improves because very hard to get long-faced children to keep their mouth shut. The DE extraction reduces face height because it intrudes the posterior segment. So that's one way, but it's not always possible to do that treatment. In your lectures, you mentioned the importance of maintaining an open bite for children in the first decade. This makes sense to me in terms of allowing mandibular growth for the forward counterclockwise rotation. Will you help me understand this better, especially in terms of when we are aligning the anterior teeth in mixed dentition patients, knowing that they still have a future growth? So there is a misunderstanding on your part. I have not ever talked about maintaining an open bite for children in the first decade. Nature does not work like that. Okay, your bite is closed for your entire life, except for a 3-year window between seven and 9, 6 to 10. All right, sometime in that 2-year period between when you lose your primary incisors and when your permanent incisors meet in the middle of your bite again. So there is a period in your life as a child where you have no primary teeth and you have no permanent teeth at the front. And then as these new incisors come through, you have a small timeline of around 2 years of age where you have a small open bite. Your incisors are still erupting and they haven't met in the middle yet. And that timeline between around 7, 8, and 9 years of age is when you have the greatest true mandibular rotation, where your chin, which is non-existent as an infant and very small as a young child, develops through true mandibular rotation to align with what we would expect to be the strength of chin for an adult. So that timeline is not a decade long. That timeline is about 2 years. Between around 7 and 9 years of age, you should have a slight open bite because your incisors, permanent incisors which are erupting, have not as yet met. You should also have a slightly forward tongue resting posture because the tongue tends to end up in the gap, which drives not only an AP dimensional improvement, but it also increases the amount of auto-rotation as well as the true mandibular growth rotation, which is forwards in a closed resting posture. So that is what hopefully will clarify to you the misunderstanding that you have. Okay, last question. Can you explain altered passive eruption and what it means skeletally? Do we need to address this other than aesthetically with clinical crown lengthening down the road? So altered passive eruption is when the gingival tissue doesn't clear from the crown up until the CEJ. So the bone obviously ends short of the crown of the tooth, and theoretically the soft tissue ends where the bone ends. But in altered passive eruption, you have the soft tissue not pulling away from the enamel and crown of the tooth. And then you end up looking like you've got really super short crowns and lots of gum. Normally, over time, that pulls away because obviously you can't have gingival tissue sitting on enamel and expect any form of attachment. In time, that pulls away until the full crown height is revealed. But obviously, once you get into your teenage years, if that hasn't happened, then you've got to determine where the gingival margins actually should be, and then you consult with the periodontist and have them help clear away the excessive coverage of the crown. Okay, that's the end of my time.
Okay, thanks, Simon. Simon normally has to head off about 45 minutes past the hour to get back to his patients, and I normally take over to answer any questions about the challenge for those of you who just joined our challenge. Thanks, Simon. Until next week. All right, so um, Simon, my brother, is based in. Let me just see if I can fix my settings. So he's based in Melbourne, Australia. And I'm in New York, so we have kind of different time zones, but try to make do. Actually, one second. But yes, so thank you and welcome again to our challenge. Let me just kind of share my screen. Some of you guys are new to Posh Orthodontics, and welcome to the challenge. It's a kind of a new way that we normally have a 2-day event. It's called our 2-day introduction to Posh Orthodontics, and we've had the most recent event in New Jersey. Back in 2024, we held it at the Hilton, and it was a reasonable size event, 150 people, roughly half online, half at the venue. People were paying $2,500 to join the in-person event. And then we started selling recordings, and now it's as low as $500-600, right? If you go to our website, you've probably seen that. But we've realized, people are so busy, spending even 2 days is difficult, right? Whether it's live streamed or sure. I mean, if we could have gotten Simon back to the US for a 2-day event, we would have loved to, but due to family circumstances, he couldn't travel this year, unfortunately. So we decided not to do the live stream and instead run a challenge. And the challenge is roughly, we call it a 30-day challenge. In reality, we give you a whole year's access to the training, but for those who want and need the CE, the challenge is do that 6-7 hours of training within 30 days, right? Which is not ridiculous. And every week we have Wednesday evening, same time. Right now it's Wednesday evening, 10 p.m. Eastern or New York time. We have the weekly Q&A. Right, so and it's recorded, and you can submit questions in advance, as some of the students have done so. And if we can't answer all the questions this week, we'll post it. We'll do it next week, etc. So you have one full year's access to all the training. Right, so we start. Where do you begin? Firstly, you need to, if you haven't, I believe everyone here has already joined the school platform where we host everything. So you just got to go school.com/GOPex. And if you haven't, if you've paid and you haven't, you go, how do I get in? It's $400 a year. But we have that special, and it's still open if you really want to consider joining this private community. It's as low as $37. It's like a crazy pre-launch. Not we just launched, so it's our first inaugural event of many. As low as $37. It's a lunch, right? So it's designed to give you an decent amount of exposure. It's not a 1 or 2 or 3 hour masterclass. This is a solid 6-7 hours We've taken 3-4 hours from the 2-day event, 14 plus hours, and included additional content. For example, there's about an hour's worth of samples of mentoring. You can see Simon mentoring students. They're the most advanced students who are paying quite a bit, per year to be part of a small cohort of, 5, 6 people in a group, and everyone takes turns, hot seated, to go through their cases. You're spending anywhere from 20 minutes to an hour one on one with Simon, well, hot seated, covering your cases. So we'll give you samples of that. And the first week, we've decided to focus on GOPex. Just go through these exercises, which a lot of people kind of go, oh, they're so simple. How hard can it be? And it's simple but not easy to do on a consistent and daily basis, right? So I'm going through this with my two boys, and if you join, and you can see here we've just launched and released the first episode. Kai and Lee, they're now 7, 8. Lee just turned 7. Kai, my eldest, is at 8.5, and we're going through this challenge ourselves. All right, they've had about a month's worth of expansion with the appliances, and you'll get to see them, going through this entire journey with us over the next 12 to 18 months. And I'm working from home, and I'm finding it difficult to put this into practice, right? So we started, and we have these exercises all laid out. Now, go through that introductory growth protocol masterclass if you haven't done so already. It's roughly 60 minutes. We've broken it into 4 parts: 1, 2, 3, 4. Free resources. Download the GOPex ebook, obviously. There's a few people who joined and got in before we made this a paid community. So if you joined the free masterclass and got into the community, and it's gated now, you have to be a paid member. It's not a huge amount, $37, or even 17 if you're an allied health professional. If you're a myofunctional therapist, dental hygienist, if you've got dental hygienists who you feel this would be very beneficial for them to learn, by all means, you can send them this link here, and they can join for $17. If they want the CE, it's only 47 for 5 hours of CE, and for dentists it's 97. All right, so if you're a dentist and you want that 7 hours of CE, and this is PACE, AGD, so it's a proper verification. Costs us quite a bit of money to do it, so we're just adding a little bit more to cover costs, etc. But you get proper CE for it. All right. Now, yeah, so that is for those who've yet to join. You can join here or reach out to us, and you get a few dollars off through joining via these other links that we've emailed everyone. But if you need it resent, just send me an email at info@posturalorthodontics.com. Find us info@posturalorthodontics. Send me an email. I can just quickly put the link here for dentists. There you go. If you haven't joined, I think there's a couple of guests here. And then for allied health professionals, you can join on this link. Yeah. Anyway, enough of the pitch, right? So, but the goal, once you completed the 60 minutes, then join your particular category, right? So dentists is in this group. Allied health professionals get access to this group of training. It's basically the same, except a couple of hours of additional training covering appliances that aren't so relevant to allied health professionals. So watch the orientation video that we released a couple of days ago. It's only roughly 16 minutes, 17 minutes, and I go through exactly, step by step what you need to do, right? So everything's laid out. You've got the GOPex ebook. You can print out or just go through on your computer. Actually, I was at Dr. Rose's clinic today with my two boys, and she had a physical copy. It's hard to get. We've been asked, where can I get these physical? I would love to have had a physical copy, but we don't have it anymore. Unfortunately, I haven't been able to find it. Dr. Sandra Khan was in charge of the publishing, and it was on Amazon. It was on her website. I think it's all sold out. So we got to figure out, hopefully she can get it back in print. But we give it away for free. You can also give it away for free, right? There's no that was always the philosophy. Spread it as far as wide as you can. These are simple but effective exercises, and they are an integral part of the postural orthodontics protocol. You're not just expanding the upper and lower with a removable. This, my brother keeps on harping, is the root cause and how to overcome it through correcting oral posture. So we created a new piece of IP here. There's a one page, and you can take a picture, and that's what I use on a daily basis to remind myself what I should be doing with my kids. And you can print it out if you want, but it's just so everyone has their phones handy, and you can just take a picture of it, put in your favorites, right? So I won't go through all this. It's pretty self-explanatory. Open mouth. You can do it in the morning. You can do it in the evening. A lot of people, like I've missed, like the first day of the challenge, I did it in the morning, but then the morning got crazy. Can't even remember what happened 2 days ago, and then had to do the evening count, right? And we made up for it. We spent 4 or 5 minutes after dinner, before or after dinner, right? You can be flexible there. And then the focused chewing, obviously at the start of the ideally at the start of the dinner, you can put a little timer on your phone, and away she goes. So these are really just three core parts, right? It's the open smile, right? So most young kids have no clue how to smile. Um, I would argue even adults sometimes don't know how to smile these days, right? Well, we're in the selfie world, so we're getting better at it, aren't we? But so in front of the mirror, probably when they're brushing the teeth, it's good, 10, 20, 30 seconds. Make sure you remind them of proper resting posture, lips closed, teeth together, tongue and palate. And then have fun. Have fun with the different expressions, right? And then this inner smile meditation, I wanted to add in that related to meditation and mindfulness practices. So, just get them to close their eyes and imagine and really be conscious of the proper resting posture. All right. And then you get them to focus and smile into their nose and smile into their heart, I beg your pardon, lungs, tummy, and whatever, right? My son has some kidney issues, and so we get him to smile into his kidneys and all the cells in his body. So it all, and then when you open his eyes, you're teaching him how to smile again. It's a fun process to do. So you just spend 1 or 2 minutes, right? Whether it's before they go to bed or when they're brushing their teeth at night or whatever, right? And I know as busy professionals, some of you guys are out the door earlier, right? So before the kids are having breakfast or whatever. Morning count, or it can be evening, right? I've changed this. If you haven't downloaded this version, not to, we want people to at least start and don't feel like it's even 10 to 15 minutes is overwhelming. All right. You want me to do what? Right? Like we all get sold the, just, have perfect abs, just 10 minutes a day. I mean, we can't even do that, let alone, you know, working with our kids, right? If we can't even discipline ourselves to do certain things, but it's even harder with kids. But if you can just do it once a day, my brother would be laughing at me, say, "How dare you make this so simple?" Right? But even that, I'm struggling to go through. I'm at least completing at least one iteration of it, as opposed to two. Like today, we were out seeing Dr. Rose, so we could only do it in the morning. By the time in the evening, we were out late, etc. So be kind to yourself, but try to be as disciplined as you possibly can. Treat it like you are you are investing in $5,000, $6,000 worth of proper treatment, like we are, and you need to do these exercises, retrain your child's poor oral posture. Um, you know, it's a few, when there's more on the line, obviously you make more effort, right? But still treat it as if your child or someone in the family is going. And if your child's already too old for this or doesn't need it, help a nephew or niece or grandchild or someone, right? Do it with your own partner and just see how how simple it is, right? But understand the challenges of parents as well. That's why compliance is always a tricky thing, and this is partly why you could argue orthodontists never wanted to deal with young kids. Wait till they're 12, pull out a bunch of teeth, whack on braces. Bob's your uncle, as they say in Australia. So much easier. But nothing ever that was meaningful and worth doing in life was meant to be easy. And, prevention, start young, and for those parents, could be the 80-20 rule in life. I don't know what percentage, but that's my gut feel. Maybe 20% of families are the really disciplined type who will do anything for their child. Send them to swimming lessons, basketball, everything under the sun to help their child grow to their full potential. And once the parents understand or are educated, and you can invite them to this challenge, it's $7 for parents. $7, less than a Starbucks coffee with oat milk. Literally. And they'll get the ebook, they'll get 2-3 hours of training, and you just send them to, and we'll be here we'll be the ones sharing our journey and educating them on the process and the importance of. I'll come back to you guys for the treatment, because they're not going to fly to Australia and get my brother to treat them, right? So we're predominantly marketing to the US crowd, as we have in the last year or two. So go through that. This first week is all about learning these simple exercises. Right? There's a few other, these are they were part of the ebook. Additional exercises that they're optional, right? Don't make them part of the complexity of, the full version of GOPex. Just keep to the simple 3 part, which Simon says all you need to focus on is chewing and counting initially. Right? I added this inner smile thing because I think it's just, a nice thing to do for the kids. And then finally, week 2, you don't have to go week by week. You can just kind of go through it all in a week if you want. It's all on demand. You just got to finish the quiz. Now, this additional 50 minutes, yeah, watch it at your own whatever pace. You can watch this out of order, obviously, whatever takes your fancy. And the quiz, finish the quiz if you complete your CE within 30 days. And then for some people have upgraded to the case review. If you want to submit your child's records, full instructions are here, and Simon will review it. Full details there. And then finally, for those who are interested in the full 2-day introduction program, you can click here and let us know if you'd like a little bit more training. That's about it. Spend a little bit of time, work on your profile, connect with people. There might be some old colleagues or people you've met at different events. These are 90% dentists, I would say, from the US. Right. So, yeah, welcome everyone. And if you have any questions, I'll answer them now. Thank you, Dr. Viet. Yeah, any quick questions about the challenge, or does anyone have not actually joined the school community? You need to click on this join now button that was emailed to you, and if you didn't do it within the first 3-4 minutes of joining, it's probably lost in your inbox or spam. So just send us an email. We'll resend the invite, and you have to click on join now, and it'll take you to create your own account, and then you can get access to everything. All right. So any quick final questions before I let everyone get some rest? Thank you, Dr. Sarah. Fantastic. So thank you for submitting a question and for joining us in this challenge. So don't feel pressured that you have to start now the exercise. You can start at any point, right? We gave you a link. Let's say it takes you a week to go through the first couple of hours, so you get familiar with, I'm a very analytical kind of guy, and it took me forever to get through GOPex and figure out how to do this. And now I've kind of tried my best to just keep it simple. And these, if you really just wanted to learn the basic exercises, they've got a 1-pager, and then you can go to the videos that relate to the actual lessons, and that's all you really need. It'll take you 10-15 minutes to learn. If you want to watch every single video, it's about 83 minutes. And then the ebook will take you 20, 30 minutes to read, right? So, yeah, so you can go through that. And then your worksheet, you don't have to print it out these days. Who has printers at home? Some people do, but you can just file, make a copy, and then download it, right? Or download it as an Excel, and then you can just put whatever start date if you want, right? Start on a Monday, you know, start on a Monday, and then it could be any week, right? And then you just fill it out, type a one and save it. Um, and then for those, who want a certificate, if you complete this, it doesn't have to be everyone. So long as you do at least the chewing and counting and the open mouth once a day, will issue you a certificate. Um, it's just a nice thing to have, right? Nice thing to complete. I'm hoping we will make it, and we'll do it every at least once a day. Oh my goodness, I think we're traveling somewhere here, and you know we'll do our best. All right. On that note, any other final questions? So before we wrap up, I know there's some folks from around the world. Shout out to Malaysia, Bogotang, where Simon and I originally were from and born from in Malaysia. Who else is still around tonight? It's getting late. On that note, I don't think there's any other questions. Wait a minute. Let's see if there's any quick questions or comments. Otherwise, yeah, this is recorded every week. We record it. We upload it on our YouTube channel. If you're not familiar with our YouTube channel, let me give you the link. So by tomorrow or within 24 hours, we upload the Q&A into um, into our YouTube channel, which is let me just quickly give you the link. It's just youtube.com. All right. So down the bottom, uh, down the very bottom. Let me just share my screen quickly before I wrap up, because I know most people cannot join. So down the bottom, you will see the playlist. Right, you can see different playlists from guest presenters of the years, case studies. Our GOPex exercises are here as well. We give everything away for free almost. Um, Ask Dr. Wong weekly Q&A. Right? So yeah, every week we upload with transcripts. Yeah, so this is where you can find it. Alrighty. And now there'll be some behind the scenes stuff we're not going to release to the public for my two boys. Like for example, when Simon is reviewing and supervising Dr. Rose on my two boys' cases, we'll upload those inside the private community. Okay, so that will be in here, the Wong Boys section. Okay, so yeah, that's part of the privilege of joining our exclusive private group, GOPex Growth Community. Alrighty, so thank you very much. We'll see you next week. Hopefully by then you'll have some questions. I know this is the first few days of the challenge and people are still going through the training and may not have any questions until the next few weeks. So we'll see you next week. All right, good night, everyone. Thank you.